So basically the aim of today is to cover some of like the really common exam topics for year 4 SBAs. So like these are kind of like the main headlines, and we did this last year, and I don't know how much of this actually came up, James.
So, I mean, we didn't have an OSCE, so I think a lot of this stuff is prime fodder for OSCEs. There's often a stats sort of station and things. I think there was a little bit actually though on like sort of capacity and advanced care planning and DNACPR. So, no, definitely high yield stuff.
Yeah, so like in our finals OSCE, we had like an ethics and law station and a stats station. So like it wouldn't be surprising if they gave you one of each as well in your OSCE. James will talk about ethics and law later, some stuff on advanced care planning, DNA CPR, capacity, confidentiality, and informed. We're not going to cover informed consent because hopefully you know that, because I swear that like I think that was one of the things you kind of learned from med school interviews back in the day as well. The bulk of today will be stats because like I think it's taught really poorly, and I don't think it's that hard if we do it properly. Specifically, we'll focus more on the testing statistics rather than like seeing how good treatments are, because that stuff is a bit easier actually. It's like the testing, like the sensitivity, specificity stuff that they like asking you about, and how do you explain that to a patient. And we'll talk briefly about collating data, because forest plots is still like something that can be examined and something that a lot of people find quite confusing. But again, we're going to simplify it, and like hopefully by the end of it, you'll find it really easy. I've also put some of Jake's old slides for reference about like breaking bad news. You should be taught that formally in the curriculum, but if you haven't, you can have a look through them, and there's like a good framework on what you can do. So to crack on, stats. You can basically what we'll do today is the stats related to different tests that we can do for various diseases. The stats you can do to see how good certain interventions are or side effects are, and then how we can like look at lots of different stats across multiple papers in order to collate them into like one easy to read piece of like evidence. Testing related stats is like what I think is the most examinable thing. So things like sensitivity and specificity, and like the med school always like they always like using these weird formulas, which I don't think are the way to go, because they don't really tell you what each of those statistics mean. And these kind of stats split into two major groups. So one is where you have the test before you've made the diagnosis. So if 100 people have a test result, how many of them will or will not have the disease? And those are the positive predictive values and the negative predictive values. The next group is the test comes after like knowing the diagnosis, and this is very useful for us in like when we're creating new tests for things. So you've already confirmed with a gold standard 100 people have a disease. You want to know how many will or will not test positive or negative on like a new test that you are creating. So those are things like sensitivity and specificity. So what does this all mean? So, and to be honest, I don't like I probably was guilty of just learning this like a bit superficially as well until I got to fourth year, where I was taught it in the context of some like real world investigations. So I'm gonna try and explain it with a slightly niche example, but I think this is the best like example of this in like clinical practice. So yeah, don't worry about these normal values, because these values, they're not important. I just need you to get the general gist of it. So we're going to talk about lupus because I'm teaching, and of course we're talking about lupus. But ANA is the most sensitive test for lupus. It's 97% sensitive and 74% specific. Anti-Smith is the most specific test for lupus. It's only 40% sensitive, but if you have it, it's almost definitely lupus. It's 99% specific. And I think like in the context of an OSCE, if this comes up, what they'd like to do is try and get you to explain this to someone who is not trained statistically. So I want you, every time you see sensitivity or specificity, I want you to think about it in terms of words rather than numbers. So sensitivity refers to people with the disease. So if you test 100 people who you know have lupus, 97 of them will test positive for ANA. What that means is anyone with a positive ANA might have lupus, so it's an excellent screening test. If they don't have a positive ANA, it's almost definitely not lupus. With anti-Smith, not smooth muscle, if you test 100 people that you know have lupus, only 40% of them will test positive. That means if you have a negative anti-Smith antibody, you might still have lupus because you're still missing out 60 people for every 100. So this is not a useful screening test. Does that make sense so far? If it doesn't, let me know and we can do it again, because this is like the crux of like stats for tests. Makes sense. Cool. Similarly, specificity is looking at people that you know definitely don't have the disease. So again, if you know that 100 people don't have lupus and you test the ANA, 26 of them will still test positive because the specificity was 74%. So what does that mean? It means ANA can be positive in other things other than lupus. So having a positive ANA does not diagnose lupus. It's good for screening for it because like pretty much everyone with lupus has it, but it doesn't confirm the diagnosis because there's lots of other conditions that will cause a positive ANA. In fact, there's how many people in this call at the moment? 17 people. If you tested all of us for ANA, there would probably be one or two of us who would test positive, and even if none of us had lupus. Similarly, if we look at anti-Smith, if you test 100 people you know don't have lupus, only one of them will still test positive. So there's very, very few false positives. It's only really raised in lupus. So if you test positive for anti-Smith, you are very likely to have lupus. And this is an excellent diagnostic test. So how this is used in real life is often if you're worried about an autoimmune condition like lupus, in GP, you order ANA, which is a cheap and sensitive test. And later on, once you have a positive ANA, you're referred to a specialist who can go on to confirm the diagnosis by testing some of these more specific antibodies. Ideally, you would have a test that is both sensitive and specific, but like those are very far and few between, and often they have other drawbacks. So like a good example of that would be doing a CTPA for a pulmonary embolus, but like that's a ton of radiation that you're putting someone through. So there are always consequences to any test or any intervention that you choose to do. Does anyone know of any limitations of like study design when you're trying to measure sensitivity or specificity? What do these rely on? What do you need in order to calculate both of these statistics? It's a bit of, yeah, so you need a very good gold standard test. So like there are, you need to like have a test that can definitely confirm the diagnosis already. So we're working on like a way to diagnose giant cell arteritis regularly, but like it has low sensitivity and low specificity because we don't have a good gold standard to compare it against. So that is like the biggest limitation of these. How do you define who has the disease? Is there a well-established gold standard? PPV and NPV are generally a bit less useful when you're creating a new test, but again, the best way to think about this is through using like a real world example. or putting it into words. So PPV is if 100 people test positive for ANA, how many have lupus? And NPV is if 100 people test negative for ANA, how many of them won't have lupus? Based on what I've told you so far, do you think that the NPV for ANA when diagnosing lupus is high or low? You can flick back through the slides to figure the answer to this question out. So not quite. It's a high negative predictive value, because if you test negative, you definitely don't have the disease. If you test positive for ANA, you might have the disease, but 2/3 of people still won't have the disease. So the predictive value isn't quite high because it's not specific enough to have like a very high PPV. Having a high sensitivity often goes along with having a high negative predictive value, and a high specificity usually goes along with having a high positive predictive value. As a general rule, that's not always the case, but that is generally the rule. Does that make sense? Yeah. Okay, cool. The way you calculate all of these is using the confusion matrix, which is aptly named because it's confusing if this is all you use, without like the understanding behind it. So splits into true positives, false negatives, false positives, and then true negatives. And I think the best way to like really get a grasp of this is by doing a little bit of practice. So here's something I made up last year. So anti-Anush is this new antibody test being developed for like this new fake disease. Can you calculate the relevant statistics? So you can have 1 minute per question. So if you get one of these questions, try and put it into words that you would explain to someone else, because it will vastly help you remember how to like actually calculate it. I'll set a timer. Another 30 seconds, 20 seconds. Right, has anyone got any answers? 62.5%. Yeah. So to go through how you calculate, very good, very good, very good. So, wow, the animations really don't work. Oh, please work. So you have 100 people who have the disease. So if we circle that, that's all the people that have the disease. So you get 80 people. How many of those people will then test positive? You want to circle the people that have the disease and test positive, which is 50 people. And then you divide one over the other, so 50 over 80. Whoops. Which is 62.5%. Anyone confused? Anyone want me to go over that again? Because this is very important, and like it is quite a common exam topic. So like I want to make sure that you really understand this. Right, I'm going to move on, but if you don't understand it, tell me, and we will go back for this. Have a go at this. Is the same thing, but we're going to do specificity now. Again, you can have a minute. I'm just going to set a timer. I will say that in an exam, you will have a bit more time than this. I think you get closer to a minute and 30. I can't remember how long it is you get per question roughly in an exam. James, do you? It's like 1 minute and 17 or 20.
Something like that. I think I always aim for 1 minute just so you can get a bit of time to go over the questions that you found more difficult.
Realistically, you will have a bit more time because there are questions that take like 10 seconds. 20 seconds left. Right. What answers did people get? 5% or 95%. So yeah, it's so we'll just to walk through it again. So you're going to circle all the people that don't have the disease. Then you're going to circle all the people who test negative out of that, which is 19. Divide one over the other. So it's 95%. Lubna, I just took it away from 100 when I was explaining it. Just to illustrate a point in how specificity is used. When you're calculating it, just don't take it away from 100. Sorry, I that's my fault. I should have pointed that out. And next is PPV and NPV. Again, if you don't understand anything, just stop and we can go over it. So again, you have a minute. This is where you stop getting nice numbers because I made it so there would be nice numbers for sensitivity and specificity and then forgot that it has to work for these as well. $20 seconds. Right, does anyone have any fun answers that are hopefully correct? 98%. So you circle all the people that have tested positive, and then how many of them actually have the disease? So 50 over 51, 98%, you've all smashed it. Good stuff. And then last one is, what is the NPV of this rogue antibody? Another 15 seconds. Oh, sorry, I completely missed that point. Thanks, James. What have people got for this? 39%, 38.8%. Yeah, I mean, you'll have it's an SBA question, so you'll get it right regardless if you're rounding. So I won't worry about anything like that. So yeah, highlight all of the people who tested negative, which is 49 people. Highlight all of the people who tested negative and don't have the disease, 19 people. So 19 over 49 is 39%. Not a great NPV. So do you reckon this is a better screening test or a better diagnostic test? So just to remind you, it has a high specificity and a high PPV, and a low sensitivity and a low NPV. So would you rather want this in GP, or would you rather want it in like your tertiary center? Yeah, this is a much better diagnostic test. Unfortunately, this is not a real disease nor a real test, because it's a bit too good to be true. It's very good. Next, we're going to talk about interventional statistics. So this is where you're going to make an intervention. You want to see what kind of effect it's having on patients. So is treatment A better at preventing a disease versus the placebo, or is treatment A more likely to cause side effects than treatment B? These are the kind of reasons you would use these statistics. The two main ones that you need to know: risk versus odds. So risk is the probability of an event occurring within a group. So if 2 people have heart attacks in a group of 10 people, the risk is 20%. Odds are slightly different. It compares the number of people affected by an event by the number of people not affected by that event. So similarly, if you look at the same group, it's 2 people have heart attacks, 8 people don't. So the odds are 2 divided by 8. It's like a ratio. So it would be 25%. So that's the difference between odds and risk. And then you can compare ratios between different groups, which is especially useful when you're comparing interventions. So the risk ratio is the risk of an outcome in group 1 compared to the risk of an outcome in group 2. The odds is exactly the same, but for odds, and it's time for more practice. Sorry, there's lots of maths. I probably should have warned you yesterday, but there is a lot of math. Oh no, why does it show answers? So you've got the study, there's 200 people, 100 in each group. Group 1 are going to use a statin, and there's 54 ACS events. Group 2 are not going to use a statin, and there's 60 ACS events. And the animations just don't work. I hate Teams sometimes. I'll go through this one. Hopefully they're going to work on the next one. So the risk of ACS in group 1 is 54 out of 100. The risk in group 2 is 60 out of 100, which translates to 54% or 60%. And you can calculate the risk ratio between the 2 groups by dividing one by the other. So with regard to group 1 versus group 2, the risk ratio is 0.9. Please work. Yeah. So I have a feeling Teams is going to screw up the animations on the next slide. So what I want you to do is to calculate the odds and the odds ratio for this study. You can have a minute and 30 seconds. You can have a minute. How would you explain the risk ratio in words? Is the risk ratio always intervention group versus control group? Yeah, it generally is. You generally give it as a ratio of the control group. So yeah, you always the control group is usually the denominator. How do you explain risk ratio in words? So it's the chances of you having. So you'd be like, if you're explaining this to a patient, it'd be like if you are on. So if like 10 people were taking your treatment in order to reduce your risk of a heart attack, and there was another group of 10 people who weren't taking anything to reduce their risk of a heart attack, the 10 people taking it, there would be 1 person less getting a heart attack in that group. So just put it in terms of real world numbers. The fewer the number of people you can relate it to, the better is generally the rule. I don't know what you find with that, James.
Yeah, like saying the risk is 1 in 20 is much better than saying 5% or 5 in 100. Just because you can then think of the smaller number of people in a room and then be like, okay, that's what it is.
Yeah. I personally wouldn't use the ratio to explain it. I'd probably just use like the figures. I'd probably just say, so yeah, if you don't take the medication, then like 5 out of 10 people would have, no, 6 out of 10 people would have a heart attack. If you do take the medication, only 5 out of 10 people would have it. So you're reducing your chance by basically 1 out of every 10 people.
I
What
think
numbers?
just knowing sorry, go ahead.
No, go.
I think knowing the direction is the most important thing to convey. So you can say that because this number is less than 1, we know that the people who are taking this drug, there's a fewer number of them who then develop a heart attack. I don't think to a patient you need to explain that it's 0.9 or 0.8, but you can say that it's going in this direction, which is why we want to start this treatment.
I agree. The only so any answers for the odds calculations? 0.78. Yeah, excellent. It's exactly this. It's basically the same, except for remember you're not doing 54 over 100. It's 54 divided by how many people aren't having ACS events. So 1.17 over 1.5. Right. Quick spiel about absolute versus relative risk reductions. So risk ratio is remarkably similar to your relative risk reduction. Use of relative risk can often inflate how good an intervention or a treatment is. So in a group of 100 people, if one person gets a heart attack instead of 2, the relative risk reduction would be 50%. You've half the number of people getting heart attacks, but the absolute per 100 people is just 1 out of 100, which is like not a huge difference. Absolute risk reduction is also useful when you need to figure out how many people do you need to treat in order to have an effect, because you can, or like the number of people you treat in order for one adverse effect to happen. And yeah, relative risk is Daily Mail stats content. They always use relative risk. So number needed to treat is how many people do you need to give the drug to in order to reduce the one event effectively. They'll always throw around the usual example of statins have a ridiculously high number needed to treat. Interestingly enough, I think I told James this last year, but one of the lowest number needed to treat drugs that you'll learn about this year is actually anti-TNF therapy. It's like you need to give 1.4 people anti-TNF therapy for one person to get an advantage from it. It's very good. They're very good. So here's a quick SBA that, we haven't set up Mentees today, but have a few seconds, think about it, and let me know what you think is the right answer. We're going to talk about significant ratios. Option D, option C, option D. So yeah, the correct option is D. So effectively, if we talk, so with the 95% confidence interval, if it involves the point of no change, which in a risk ratio would be 1, because there would be no difference between the two groups if the risk in both groups is the same. So if the risk in group 1 was 60 and the risk in group 2 was 60, 60 over 60 is 1. If it involves that number, then it would not be statistically significant. With C, the reason C is wrong is because if the risk ratio is greater than 1 without the confidence interval being included, then you would suggest there would be an increased risk of ACS that is statistically significant, because it would be higher in the first group rather than the second group. And yeah, that's a good question. What number do we watch out for what number do you want to avoid? Yeah. So with an absolute risk reduction, you want to avoid 0 because that means there's no significant difference. So all of this is like even more useful when you look at forest plots, which are often produced from like meta-analyses. So which of these trials is significant is the first question with the information you've just been told. Doran is significant because the line, which represents the confidence interval, does not include 0, and Auckland is. Good. What does the diamond show? By the way, this isn't a real trial. I also have no idea what statistics this is showing. So the diamond shows like the overall effect based on the different weightings of all the studies for statistical significance and the overall result. Yep. And overall, is there a significant reduction in ACS? If let's pretend this was for ACS, which it may well not be, because I have no idea what it's for. Yes, there is, because the diamond doesn't cross 1. So here's a quick little bit on, oh yeah, PS, not real study. Here's a quick thing on how to look at forest plot. You have, so when you're looking at the individual studies, the midpoint of that big box shows you the result of the study. The 2 whiskers on either side show the 95% confidence interval for the study. And the size of the box in the middle is proportional to its weighting within the meta-analysis. So in this case, the Auckland study is significantly more weighted than anything else. Looking at the diamond, the overall result is the midpoint of the diamond, and the two corners on either side of the middle of the diamond show you the overall 95% confidence interval. And providing that doesn't overlap 1, that is a statistically significant result. Any questions about stats? Speak now or forever hold your peace. Not forever. Actually, please don't do that. If you do have questions after, yeah, message one of us, because like it does come up. Yeah. So the Auckland study was statistically significant. Okay, can I zoom in? I can't zoom in. If you look very closely using a magnifying glass, you can see that neither of the 2 whiskers on either side of the Auckland study cross the line at 1. So the 95% confidence interval doesn't include 1, therefore it is statistically significant. Does that make sense? No worries. So that's like the main stats that comes up. There's some stuff that can come up on study design. It tends to be less examined. We might cover it as a bit of a footnote at some point when we think it's relevant, or we find like a good example for it, but have a read of stuff like that. Other than that, I'll hand over to James for ethics and law. I need to go to another meeting, but I will pop this on my phone. So if you have any questions, yeah, I'll answer on the phone.
Sweet, thanks very much. So we're just going to talk through a few sort of key points, I think, about just generally important to you as future doctors, but also things that come up quite easily in OSCEs. So the first we'll talk about is capacity. And the most important thing to know is that you think about capacity whenever you need to ask the patient for their consent over anything, but it's decision and time specific. So in the morning, if you see a patient and you decide they don't have capacity, if you're going to try and do another thing in the afternoon, you need to assess their capacity again. Can anyone tell me what the 3 requirements for valid consent is? So if I'm consenting to give some antibiotics, what 3 things do I need to establish? Okay. So that's more specifically to do with capacity, right? So those are all excellent answers with regards to capacity, of which one of them is the requirements for consent, and Niraj has hit the nail on the head for the other ones. So it's not coerced, and they're fully informed about the benefits and risks for that. But capacity, which you guys have explained very well, is there. So the thing that underpins how we assess capacity is the Mental Capacity Act of 2005, and it has these 5 key principles. Number one, assume it's like innocent if not proven until proven guilty. So assume they have capacity until you prove that they don't. And 2, you've got to do everything you can to help make sure the patient has capacity. So, for example, if someone has learning disabilities, and you know that their symptoms are worse when they don't have their carer present, try and have the carer present and facilitate that and see if their capacity improves with someone that they're familiar with. Number 3, just because they make a decision that you don't agree with does not mean that they don't have capacity. Similarly, if they believe in homeopathy or have beliefs that don't match with yours, it doesn't mean they don't have capacity. Number 4, this is at the point that you've decided that they don't have capacity. If you do make any decisions for them, it has to be done in their best interests, and we'll talk about best interest decisions later. And then number 5, any sort of decision you make about that has to be like as least intrusive as possible. One important thing to think about, which is lovely displayed in this sort of flow chart here, is if you don't think they have capacity, the first thing that you should actually think about is, can we wait? Is this life-saving treatment that we need to think about now, or potentially will they have capacity tomorrow morning, and we can wait for them to make a decision then? Usually, if a decision can't be deferred, you'll then go through the next steps, but always have that sort of check-in first, before you then consider the next steps. So we'll talk about the next steps a little bit later, I think. So assessing capacity, we've already talked through that. So can you understand the information? Can you retain it? Can you sort of weigh the pros and cons or rationalize a decision? And then can you communicate it back? And we've got to do everything we can to facilitate that. What happens when a patient doesn't have capacity? We talked about our first thing that we ask, which is, can we delay the decision? If not, then we check for any legally binding decisions made by a patient. And does anyone know any specific terms that might be hinting towards? Good. ADRT, which is advanced decisions. So well done, Sylvia, Jordan, and also Jessica, well done. An LPA as well is also a legally binding decision. And if there is no ADRT and there's no LPA, then we've got to try and make a best interest decision, which is our point 4 on the 5 pillars of the Mental Capacity Act. It says using all available evidence. Do we know what, as doctors, we're legally required, who or what we're legally required to consult in making a best interest decision? Good. Yeah. Well done. We have to consult. We have to consult the patient's family, and that's because the family know the patient best. And so it's to weigh up what they think the patient would want and weigh up what matters to them. But importantly, it's not that the family get to decide, but they're just involved in this process. Okay, they're consulted in this. Got an SBA for you, and I hope the answer isn't shown. Here we go. So which of these patients is least likely to have capacity? Take 30 seconds, and then at 30 seconds, I'll ask you to post your answer, just so everyone has a chance to think. Actually, I'll give you more than half a minute. I'll give you a full minute. I'll be nice. Okay, so if you could start posting your answers now. Oh no, I've clicked on the wrong button. Sorry. Okay, so lots and lots of E's, which is great. All hit the nail on the head. Well done. Let's go through each of the others one by one and explain why they might still have capacity. So why might A still have capacity, or why is it not? Why can we say they don't have capacity? Yeah, they could have schizophrenia, which is well controlled. Just because they have a mental illness doesn't mean that they have they don't have capacity. And the other thing is, just because they're rejecting antibiotics, just because they're making what we think is an unwise decision, doesn't mean that they don't have capacity. So that's our third pillar. Good. On to B. Why do we not think? Why do we think that B might not necessarily lack capacity? Good, yeah, moderate Alzheimer's disease, but even severe Alzheimer's disease, we should still, do a capacity assessment, and there's still a chance that they have capacity. So diagnosis that feature sort of cognitive impairment doesn't necessarily preclude capacity, if you think that they can retain and weigh up these decisions. C is similar to what we discussed in A. An unwise decision does not mean that they lack capacity. What about D? Locked-in syndrome. Yeah, really, really good. So they can move eyes, so they might be able to communicate with eye movements. And so we should try every way that we can to facilitate that communication. And that is point number 2 of the pillar. So do everything you can to facilitate capacity. Good. Any questions of what we've covered so far? What I'm going to do is I'm just going to go back to this flow chart so you can see the sort of order that we do things. So firstly, do we need consent for anything? Do we need to assess their capacity? Because remember, we assume people have capacity unless proven not. If they don't have capacity, can we defer the decision? If not, let's look at the legally binding things. So LPAs, advanced decisions, and then if they don't have any of that, we consult a best interest decision, where it's really important that we speak to family, but we also refer to advanced statements, which we'll talk about in a second, and then IMCA. Does anyone know what IMCA stands for? And when we'd use them? Very good. Independent mental capacity advocate. But what does that actually mean? Yeah, exactly. If a patient doesn't have a next of kin, then we can use the independent mental capacity advocate as someone who's separate from the team, who can help us sort of ascertain what their best interests are, and hopefully they'd be able to look through documentation or written things from this patient and help sort of get an idea of what the patient might want. Very good. I'll take the fact that we haven't had any questions to mean that you're all relatively happy with this, and we'll move on. So advanced decisions. This is what we talked about ADRTs, or they're often known as living wills. What's useful to know is they can actually be verbal. It doesn't have to be a written contract, but in most cases they will be written, because usually advanced decisions to refuse treatment is typically about life-sustaining treatment. So in any case, if you're making a decision about refusing life-sustaining treatment, it has to be written down and signed and witnessed. It allows you to record any medical treatments you don't want in the future. It's refusing things, not asking for things. So you can't say, oh, I want to be intubated. It's just that I don't want to be intubated when I'm 80 plus, and that. It's really important that advanced decisions are very specific. So you can't just say, oh, I don't want to be intubated. You need to give the scenario for which you wouldn't do it as well. So I don't want to be intubated if I get hit by a bacterial pneumonia. So no, they refer to the same thing. It's really confusing because there's different wording, but advanced decisions is the same as an advanced directive to refuse treatment. So good question.
I would pick one and just learn it. I would pick like a name for it and just learn it, so you don't confuse yourself in an OSCE under stress where you know like 3 different things. And I was also going to say I would just learn it as advanced decision to refuse treatment, because like that distinguishes it from something James is about to talk about in a minute.
And I'll tackle that question from you, Jordan, in a minute. But yes, learning as advanced decision to refuse treatment sort of makes sure that you know it does what it says on the tin. It's about refusing treatment, and this is the one that is legally binding. How old do you need to be to make an advanced decision? To refuse treatment? $18. Very good. Yes, so the answer is 18. You need to be 18 or over. I think in Scotland it's 16, which is a bit confusing, but for the most part, 18. Good. On to the next one, advanced statements. So these are not legally binding, and it's for you to document your wishes and anything that's important to you. And this is what we consult if we have to make a best interest decision. So often it just helps us get an idea of the patient's, say, religious views or their preferences, whether they prefer orange juice or apple juice. It can be anything, but it's not legally binding. So we don't have to, you know, it's not as strong as an advanced decision to refuse treatment. And maybe if you get mixed up between decision and statement, I suppose stating something isn't something that's as binding as a decision that has been made. But yeah, you just learn it as advanced decision to refuse treatment or advanced directive to refuse treatment. Any questions about the difference between an advanced statement and an advanced decision? Okay, fine. So moving on, we're going to talk about lasting power of attorneys. So the most important thing to know, actually, there's a couple of important things to know. First thing is there are 2 different types of lasting power of attorney. Okay, there's ones that look after health and welfare, and there's ones that look after property and finances. So if a patient's relative says, "Oh, I'm their LPA," it's really important to clarify over what. Are you the LPA over property and finances or health and welfare? Because if they are in charge of property, they shouldn't be able to make statements about their health. Okay, so an LPA doesn't necessarily mean that they can make statements about the health. They have to be the LPA with regards to health and welfare. These are also legally binding. So they're one of the strongest things that we refer to if someone doesn't have capacity. We go for the LPA and the ADRT. And it gives another adult legal authority to make decisions about their care for them if they don't have capacity. So it's a legal document. You sign it. Again, it has to be signed, witnessed, and you have to have capacity, I should say, for both this and the advanced decision to refuse treatment. You have to have capacity when you made that. Otherwise, it's not valid. Perfect. It's worth noting as well that the LPA isn't making decisions that they want. They should be making decisions in the patient's best interests and in what they view that the patient wants. Good. So on to another SBA. Again, I'll give you a minute and then we'll post answers and then talk through it then. Is anyone else hearing weird? Oh, sorry. I think my internet's acting up. I'm not sure what's going on. I'm hearing some really garbled speech.
It's a common question.
I got very afraid that I was being abducted by aliens, but I'm glad I'm not the only one. Hopefully it's resolved now, and hopefully you can hear me clearly. Fab. Did anyone have a question? Okay, fine. So if people could start posting answers, what are we thinking for this question? Fab. D, well done. Because if we remember in our flowchart, before we consult the legally binding things, the LPA and the ADRT, we need to assess their capacity and show that they don't have capacity. Again, it's the same thing here. Each decision, every time we assess capacity, it's decision and time specific. So we don't know currently, even though they have Lewy body dementia, we don't know whether they have capacity. So that's our very first step. First, we assess the capacity to decide whether they can decide for themselves, because if they have capacity, they can override anything they've done earlier. They can override the LPA, they can override the ADRT, but that's our very first step. If they don't have capacity, which is the correct answer? So assuming that we've assessed their capacity, we establish that they don't, which one takes precedence, the LPA or the advanced decision? Good, yeah. So we go for the most recent. If it's the case that he had the LPA first and then made an ADRT, because the ADRT was more recent, then the ADRT can override the LPA. What's also useful to know in practice is that often the LPA form has a box about any pre-existing ADRTs that you made that you want the LPA to stick to, in case you're worried about the LPA overriding your previous decisions. Is that the beginnings of a question, Niraj? Oops.
It wasn't my finger slip, sorry.
Okay, no worries. Fab, moving on. Okay, so DNAR. I think this probably comes up more in 5th year, but it's still really important to be happy discussing in 4th year. So what DNACPR is applies, firstly, it applies only to CPR. We can still give all other treatments. We can give antibiotics, we can intubate, we can put them in ITU. It's just about CPR. And this is a decision made by the medical team and signed off by the consultant. It's not made or requested by the patient. It's worth saying if the patient says, I don't want to be given CPR, then that would be another reason for doing a DNACPR. But ultimately, it's the medical team that signs this off. Okay. I think in 5th year, you go more into sort of counselling a patient about why we put on DNACPRs, because it sounds like sort of, I think to people who don't understand why we do it, it's quite a distressing thing. It sounds like we're giving up on the family. It sounds like we're not trying to keep them alive as much as we can. But it's because CPR is just a very, distressing process. You fracture ribs, you can cause pneumothoraces. And even if we do manage to save the patient's life, which is a very, very, very rare occasions, like 10 to 20%, and that's including healthy people, the quality of life can be very poor. And so while they may have an extra few hours, it's a very poor quality of life. Any questions? Okay, moving on to confidentiality and consent. Remember, if you're speaking, for example, in an OSCE scenario, and a relative asks to speak about a patient, you need to make sure that you have the consent from the patient. You also need to check that the patient's details and that they know the relative's details and that the relative knows your patient's date of birth or things like that. So just a few things to get at the beginning of each of those stations. Implied consent is a fairly niche thing. I don't think we need to worry too much about that. It's on the slide for you to look at the end of the day if you want, but it's just often how we sort of use research or how we pass information between teams. Moving on, when can we disclose information without consent? This is really important. So firstly, if a patient lacks capacity, so we can't get their consent to give their information. And we think that the disclosure is of overall benefit to the patient. Again, this sort of best interests decision of the patient. There's stuff if you're legally ordered to do so, which is things like communicable diseases, serious crime, terrorism, FGM. This is a very specific one, Road Traffic Act, which is why we have all the DVLA stuff, which Pass Med loves, and unfortunately medical schools love too. Knife and gunshot wounds. This sort of question comes up a lot. Someone comes into A&E with a knife and gunshot wound. What do you tell the police, or do you tell the police? And the current guidance is we are required by law to inform the police, but we do not necessarily need to give the patient's details. So we would say, hello, I have another patient that's come in with a stabbing. They came in 2 hours ago. And if the police come and they want to speak to the patient, if the patient doesn't give consent, or the patient doesn't want to speak to the police can't speak to them. The reason why we're required by law to tell police is so police can use it in their statistics and sort of figure out which areas have increased areas of knife and gun crime, so they can better sort of distribute their resources and things. But you're not necessarily dobbing the patient in, for example. And then the final point is if they're ordered to by the court or by law. If you do have to break confidentiality, it's really, really important that you speak to patients first, unless you think that telling them might cause harm to other people. So often, if you had an SBA and what's the next most appropriate, what's the most important next step to do? If you establish that you have to break confidentiality, it's actually inform the patient that you're going to breach confidentiality. Any questions from that? I appreciate that's quite a lot of random things there, and this has in the past caused confusion. Fab. Okay, well, we've just got some slides at the end about breaking bad news. I won't go over it now. It's once you read through the slides, I'm sure you've been taught it much better anyway, and the slides just have a nice summary for you to look at in your own time. But that's all we had prepared for CPP today. So the stats, being able to make those calculations on sensitivity, specificity, and the sort of ethics and law, consent, capacity, what happens if they don't have capacity, what are the next steps, what are the legally binding things we need to do, and when might we break confidentiality. Good. This is more of a thing that comes up in 5th year, but if you feel like you have to discuss confidentiality with a patient, think about how you'd word that. You don't necessarily say, everything we say is just kept between you and me. You do have to say, I won't be sharing this information with anyone else unless I think there's risk to you or to other people. So just get used to how you would say that in your own words. Anush has just posted the teaching feedback form, which we really appreciate you filling out. To help us guide what you want next, what you think you'd like more of, what teaching styles you prefer, just so we can crack on things and make sure we're doing it right in the last few weeks before exams. I'm happy to stay on for the next 5 or so minutes if anyone has any questions, whether it's statistics related or CPP related, and we can discuss. But thank you for tuning in and have a nice evening.